Jimmy was taking a shower as usual, getting ready for the morning bus to school. 2 months to go and he would be in college. Just then, he started to feel a strange sensation down there. It started slow like a gentle squeeze, but very quickly the gentle squeeze turned into a very firm hold as he felt everything move up as though it was trying to go back inside him. He fell to the ground reflexively, barely able to move. The shower water was pelting down on him, and every time a drop hit him below the waist, it felt like a tiny dagger piercing his skin. He had been kicked there before. In fun, of course, as young dudes sometimes do. But this felt like a train had hit his testicle. He clutched and groped at himself, pulling downwards, hoping it would relieve the pain, but nothing did. He started to cry uncontrollably. It must have been quite loud because his parents started banging on the door. His dad was ex-army and easily kicked the door in. Jimmy's pain was now compounded by his embarrassment. He pointed to where the pain was coming from. The testicle had begun to turn a reddish hue, and was already growing in size. His mother started to cover him, leading him out the door and chasing his younger siblings away. He couldn't contain himself. Crying and telling her over and over that he hadn't done anything up to now, he didn't even have a girlfriend. She reassured him, but shot a worrying look over to his father, who was already calling an ambulance. This case is one you will often find in an emergency setting. What do you think he has? Epididymolyarchitis. Appendicitis. Torsion of the testis. Testicular tumor, or testicular rupture? Given the history of non-traumatic, sudden onset testicular pain and swelling, especially in a non-sexually active male in his early to late teens, the most likely diagnosis is testicular torsion. He arrived at ER 1.5 hours after the pain started. How much time do we have before the testicle is no longer viable? To ensure that we are definitely going to save it, we should relieve the torsion within 4 hours. But up to 6 hours is still regarded as within the salvageable window. What can we do in the emergency room? 1. Rapid assessment, prompt evaluation of symptoms and physical examination. 2. Pain management, administer analgesics to manage severe pain. 3. Ultrasound imaging, perform Doppler ultrasound to confirm reduced or absent blood flow to the affected testicle. 4. Urology consultation, immediate referral to a urologist for surgical intervention. 5. Manual detorsion, attempt manual detorsion as a temporary measure if surgery is delayed. Note, this should only be performed by a trained professional. How do you perform manual detorsion? 1. Immediate action, attempt only if surgical intervention is delayed and by a trained professional. 2. Patient positioning, place the patient in a supine position and expose the scrotum. 3. Analgesia, administer appropriate analgesia to reduce discomfort. 4. Determine side, identify the affected testicle, usually higher and horizontally placed. 5. Direction of rotation, rotate the affected testicle outward, like opening a book. For the left testicle, rotate clockwise. For the right testicle, rotate counterclockwise. 6. Gentle movement, apply gentle, steady pressure during rotation, usually about 180 to 360 degrees. 7. Monitor response, assess pain relief and detumescence, reduction of swelling, as indicators of successful detorsion. 8. Repeat if necessary. If initial detorsion is unsuccessful, a further rotation may be attempted. Beyond this, there is not much that can be done in the emergency room. If you have a high-frequency probe on your ultrasound or immediate radiological services, then a scrotal ultrasound is a great investigation, but only if you have doubts about the diagnosis. Not like our patient where it is obvious. However, some urologists will insist on an ultrasound before consulting if they know the service is available. This is not to give you extra work but to exclude other causes or mimics of a torsion. Let's compare 2 testes that were investigated on ultrasound and note the difference in vascular flow of the healthy right compared to the left. It's important to understand why the change in vascular flow, so let's look at what happens during a testicular torsion. While the images may be funny, it's important to understand what is happening in the testis and its potential ramifications. 1. Anatomical factors. Testicular torsion often occurs due to an anatomical abnormality called the belt clapper deformity. In this condition, the testis is more freely mobile within the scrotum, allowing it to rotate more easily. 2. Twisting of the spermatic cord. The condition starts with the rotation of the testicle and the spermatic cord, which suspends the testicle and the scrotum. This twisting can occur spontaneously, often without a clear cause, though it may be triggered by physical activity or trauma. 3. Impaired blood flow. The torsion obstructs the blood vessels within the spermatic cord. This obstruction compromises arterial blood flow to the testicle and impedes venous return, leading to swelling and ischemic injury. 4. Ischemia and cellular damage. Reduced blood flow results in ischemia to the testicular tissue. Prolonged ischemia can cause cellular damage and even necrosis if not promptly resolved. 5. Inflammatory response. Ischemia and the subsequent reperfusion, if blood flow is restored, can induce an inflammatory response, potentially causing further damage to the testicular tissue. 6. Pain and swelling. Ischemia and inflammation in the testicle lead to the onset of severe pain and swelling, which are characteristic symptoms of testicular torsion. 7. Risk of infertility. Prolonged torsion can lead to irreversible damage to the testicular tissue, potentially affecting fertility if not treated urgently. 8. Potential for bilateral effect. Although torsion typically affects one testicle, the underlying anatomical abnormalities can be bilateral, posing a risk to the other testicle as well. In conclusion, let's look at the differential diagnosis of testicular torsion or an acute scrotum. Please take a screenshot for future reference. 1. Epididymitis/architis, gradual onset, fever, urinary symptoms. 2. Testicular appendage, localized tenderness, blue dotsia. 3. Inguinal hernia, bulge in the inguinal area, groin discomfort. 4. Trauma to scrotum, swelling, bruising, pain post-injury. 5. Varicocele, bag of worms feeling, usually painless. 6. Hydrocele, fluid accumulation, scrotal swelling, not typically painful. 7. Testicular cancer, painless mass or lump in the testicle. 8. Idiopathic scrotal edema, swelling, redness, mild pain. 9. Urinary tract infection/kidney stone, referred pain to scrotum. Thank you for tuning into ER Mentorship Hub. We hope this video not only informed but also captivated your interest in emergency medicine. If you found value in our content, please consider showing your support by liking, sharing, and subscribing. Your engagement helps us grow and continue to bring quality medical education to you. Don't forget to hit the notification bell so you never miss out on our future videos. Thank you once again for being part of our community, and remember, every day is a learning opportunity in the world of emergency medicine.